Okay, we're recording.
Hi guys, welcome. So myself and Niraj are here today to give you guys a bit of teaching on doctors ABCDE and ABGs. So the plan for the session is going to involve running through the ATE basics and then applying what you guys have learned to a clinical scenario. And then the second half, Niraj will continue that scenario with some teaching on ABGs and give you a chance to interpret a few, do a few SBAs as well, and look at the clinical scenario at the very end and how you'd manage that. If you haven't already, then just hop onto the VBox. The idea will be on the slides, and that gives us a chance to kind of interact. And a lot of this will be kind of question and answer based. So feel free to throw any ideas, right or wrong, into the Q&A. It's the best way that we can run the session. So we'll start off with, when do we use the ATE approach? So if you guys want to start putting your ideas into the Q&A chat. If it's easier for you guys to put it into the Microsoft chat, the Teams chat, then feel free. Perfect. Yeah, thank you so much. So I'm just opening my chat. Acute emergencies. Perfect. Yep. Thanks, Ria. Feel free to use the chat, guys, since there's only a handful of you. Exactly. So essentially, it's when you're reviewing any kind of unwell patient. So emergencies, that's bang on. And especially when, as a fourth year, when you're examined with ATE, it's often in very kind of critical illness. And so along those lines, can you guys think of any examples? So what sorts of conditions do you think, especially in exams, that you might get that will require you to apply the ATE approach? And there's a whole list of them, so there's not really many wrong answers. Heart attack, exactly. Very popular one. Any other ideas, guys? Stroke, great. There is a very long list, but those are great starting points. So these are just a few that I thought off the top of my head. There are a lot more, but these are all kind of conditions that you guys can get, especially in an OSCE. So ATE is really useful to get to grips with as quickly as you guys can, because pretty much every year there is an OSCE station that will require you to show the ATE approach. So these are just a few examples of conditions that you'll have to manage. And the approach is basically the same for each one. And there are just a few minor kind of differences between each as to how you manage and, you know, who you call for help and that sort of thing. But the session for today is merely just an introduction to look at what the right approach is. And then as you guys progress through the modules, you can have a look at what kind of specific things you need for each condition. The other thing to point out is the reason we use an ATE approach. So A will kill you before B, before any problems in C, and we'll have a look at what those things are. But there is a reason for us using a methodical approach, not just because it follows the alphabet. So, oh, have I skipped ahead? No, I haven't. Right. D. So what does D stand for? I'm sure you guys all know. Disability, good one. I know a lot of people who do think D stands for disability. There's another D in ATE, which is disability. Any ideas what the first one might be? So before you've even approached the patient. Diabetes, good idea. Unfortunately not in this case. Danger. Well done, Ria, bang on. So danger. So what sorts of things are you going to be looking for? What sorts of things might you be saying in an OSCE context, let's say, that may potentially cause? Yep, if you're outside, that's a very valid answer. Perhaps maybe more in kind of the hospital setting. What sort of things do you reckon? Spillages, sharps, exactly. Along the right lines there, well done. So, I mean, these can be a wide range of things, but often kind of the classic line is it safe to approach the patient? But as you said, any kind of fluid, that could be a slip hazard, loose wires are another classic one. And quite relevant at the minute is any sort of kind of COVID measures you might need to take. So you may find that there are goggles, a visor by the bedside that you might just need to put on before approaching the patient. So that's another one to bear in mind as well. So moving on to R. What does R stand for? Response. Perfect. So response, how might you go about assessing a response in a patient in this context? And this seems like quite an obvious question, but just to break it down. Fantastic, well done, Theo. So say their name exactly. You might shake, look at some pressure points, and we'll look at when we might progress onto that. But that's exactly the approach. So you'll start off by checking, is the patient talking? So often you might go in, if you've got their name, you might say, you know, hi, Sylvia, how are you feeling? And if they're able to respond, then you know they're able to talk. But in the instance that they aren't responding to you or they're not talking, what might you do next? You've alluded to kind of shaking them or perhaps looking at the pressure points, but anything you might want to do specifically before that? So before moving on to shaking or kind of seeing their response to pain, you might actually want to see whether they're able to respond to your voice. And the way you might do that is actually go up to them and check in both ears, just in case there are any hearing difficulties. You'd want to speak to them in a very loud, clear voice into both ears. And then, like you said, Theo, shake and check their response to pain as well. So often you go for the trapezius muscle here and give it a squeeze. But then what if they're unresponsive even to that? What are you going to be doing next? And this can sometimes happen in an OSCE station as well. Call for help, very good point, and we're going to come to that. Just before calling for help, is there something you want to kind of assess? If they're unresponsive, what are you going to be worried about? So maybe having a think about signs of life. So are they breathing? You might want to check for a central pulse as well. And then if there's an indication that perhaps you need to start chest compressions and the basic life support, then you'll go down that pathway and you guys will do some kind of learning around BLS as well. So it can very easily turn into a scenario where actually you start off with A to E and then start going down the BLS route in a station. So that's where we'll assess for response. We'll go straight on to the S. So people sometimes refer to it as Dr. ABCDE. I find it quite helpful to remember it as doctors, A to E. Yeah, absolutely. As James has said, always worth calling for help really early. And that's what we're going to discuss now, actually. It's a common pitfall in OSCEs, especially in a time-pressured environment. So I guess we've kind of jumped ahead anyway. S is really helpful to think about shouting for help. So often if you find that you forget it, it's a really good structure to have just to make sure you don't, but the earlier the better sometimes. This is easily forgotten. And when thinking specifically about, as well as shouting for help, is there any kind of specific numbers you guys might have learned within a hospital, people that you might want to call for help? Any kind of calls you might want to put out? Exactly. Well done, guys. Both on the ball there. 2222. And also I've included here, you might want to even fast bleep the anaesthetist. So they often say a GCS below 8. Sometimes if you find that, and we'll kind of briefly look at this, but if you find that actually there might be something to do with kind of the airway that might require an anaesthetist present, then you might also want to consider the input there as well. But you know, that might be situation specific, but just for you guys to be aware. So moving on to the A to E aspect, what does A stand for? Airway, fantastic. So, oh, jumped ahead there. So what sorts of things do you guys think when you're assessing the airway? What are you going to be doing, looking for, feeling for? So there's a whole kind of list of things to do in this part, but if you can throw in as many as comes to mind. Foreign body, yeah. Check the airway, yeah. How might you do that? Look inside the mouth, well done. Look in the mouth, Ria said, tilt the head, excellent. Look inside, okay, if it's clear, tilting the head. Seeing if the patient can talk, good. Chin lift, great. Well done, guys, good ideas there. So starting off with the basics, looking. So there's a structure that you can follow with everything from A to E, and we'll have a look at that with A. So looking, as you guys have said, foreign bodies, is there any vomit, any tongue swelling? So even if they're able to talk to you, it's quite important to check whether there's any swollen tongue. That might suggest something like anaphylaxis. And then moving on to feeling. So palpating the trachea is another one. So sometimes you might find the trachea is shifted one way or the other, which will give you an idea of anything else that might be going on with the lungs, for instance, something like pneumothorax, which you might have to manage. So the next step is to listen. So I guess sounds that you guys want to kind of commit to memory is things like stridor, gurgling, snoring, maybe even wheezing as well in something like an asthma attack. And especially in an OSCE station, these are kind of words that you want to reel off. I'm listening for stridor, gurgling, snoring. And then the next part of the structure is measuring. So I guess it's on the slide already. I was going to ask you guys what you'd measure, but oxygen and respiratory rate. And sometimes this is something that I know originally when I was learning this, I kept this in the next part under B, but it's quite helpful to talk about or even mention getting oxygen saturations or a respiratory rate quite early on. If it means that the nurse that's helping you hasn't done it yet, or if he or she's already got it to hand, then you get those readings early on and then you can reassess as you need. But I found it quite helpful to kind of ask for this early so that when you do get to the next stages, you guys can ask for those values again, see if anything has changed with any interventions. And then the last bit of this is treat. So are there any obstructions that need removing? Do you need to put in any airway adjuncts or carry out any maneuvers? So you guys spoke about chin lift and tilting the head. Any kind of suction, or in the case of anaphylaxis, adrenaline goes with A. So you always give the adrenaline in the airway aspect of it. Can you guys think of any instruments that you might use to suction or any kind of airway adjuncts that you guys might be familiar with? No worries if not. I know this early in the year I didn't have much familiarity with equipment. Yeah, and Niraj just put in the exact dose you need to learn. You need to know that by heart. Any ideas for nasopharyngeal airway? Exactly. Thanks so much. Sometimes referred to as NPA. So that's an example of an airway adjunct you might need to put in if there's any problems with the airway itself. And there's also a LPA, so laryngeal pharyngeal airway. And in terms of suction, you might use something called a Yanker adjunct to help you with suctioning as well. And these are all things that you kind of put in, but only as far as you can see, so as not to cause an obstruction. So those are all equipment and it's useful. I would advise, and as you guys spend more time in clinics, you'll get familiar with them, but make sure that you know what these things look like, especially kind of in exam content. These are equipment that might be sitting by the bedside that you need to be really comfortable recognizing and being familiar with. And Niraj just put an excellent resource there for you guys to have a look with pictures as well. Okay, so I'm going to move on. I'm aware of time. What does B stand for? Breathing. Fantastic. Thank you, Theo. So breathing. So thinking back to the look, feel, listen, measure, treat kind of algorithm. Let's start off with look. So what sorts of things will you be looking for in breathing? Chest wall expansion. Excellent, Ria. Yeah. Anything else? So I've got down here chest expansion, any signs of respiratory distress, so things like maybe nasal flaring, that sort of thing, cyanosis, another good one for what you're looking for as well. Cool. And then for feel, chest expansion again, and like you do as part of your respiratory exam, chest expansion and percussion. And how about listen, if you think back to your resp exam? Auscultation, exactly, front and back. Oh. Thank you, Moksha. That's exactly it. So you want to be listening to the chest, seeing if there's actually air entry. Are there any unusual sounds that you need to be aware of that might give you a clue as to what's going on? And then for measure, our lovely ABG, which Niraj will be giving you more teaching on, and a chest X-ray is really important to order at this point as well. And then remember, oxygen saturation and respiratory rate. Again, if you haven't already got it, or in the case that you've actually treated it with something, you want to keep reassessing these at every stage. Any ideas of things that you can use at this point for treat? So in kind of the acute setting, what sorts of things do you think you'll be giving them at this point in breathing? Inhalers, yep, and you might be giving nebulizers at this point as well. Excellent, Hugo. I.e. salbutamol, yep, excellent suggestion. Anything else? What if I told you the oxygen saturations are really low? What are you going to be giving them? Oxygen, exactly. And the classic is 15 liters per minute, high flow oxygen via non-rebreathed mask. So that's another one of those phrases that you want to be learning. So oxygen, you might want to reposition them, nebulizers, as you said, and you might want to consider non-invasive ventilation. But normally it's those kind of first three that you'll be thinking of. Perfect. And we're going to move on to C. I know we've got a few more minutes before I hand over to Niraj, so we'll speed through the rest. So C stands for circulation, excellent. And you're going to be looking for, again, cyanosis. Are the patients sweaty, pale, and having a look at the JVP as JVP as well. Is it raised? That's a really important one. What sorts of things do you think you'll be feeling for? That is very cool. I agree. Feeling for the pulse? Yep, good. Is there a weak pulse? Is it rapid? Excellent. So also feeling for the peripheral temperature, and by that I mean literally just feeling the hand. Do they feel cold and clammy? Do they feel very hot to the touch? And also for any edema, particularly pitting edema as well. What sorts of things would you be listening for? So we auscultated the lungs this time. What would you do for circulation? Listening to the heart. Excellent. Yep, Hugo, that's it. So listening to the heart sounds. Are the first and second heart sounds present? Are there any added sounds? That sort of thing. What things will you measure? So I think circulation is really the hardest one that I found to remember because there's a very long list compared to the other sections. So what measurements are you going to want at this point? Blood pressure, excellent. ECG, perfect. Thank you, Theo and Ria. What else will we want? Heart rate, exactly. And just a couple more. So heart rate, capillary refill time is another one. Blood pressure, ECG, a urine output as well. And in the case that maybe they have a catheter, you can get a bit more of an accurate urine output. In the case they don't, then you might want to consider catheterizing the patient, and that's something we'll come to in the treat part of this. And also bloods. So in order to maybe, we'll come to that later actually, but with bloods, it's quite important that you guys are aware of what bloods are relevant to the situation at hand. So by this point, you'll get an idea of what's going on. So it's important that as opposed to saying, I want some blood tests, you want to say, okay, I want a full blood count, U's and E's, LFTs, that sort of thing. And make sure that each one has a reason as to why you're taking those bloods. But those are kind of specifics. And in terms of treating, especially if you've got things like a low blood pressure, you want to be giving them a fluid challenge. So in order to do that, you need access into the circulation. So the classic is putting in 2 wide bore cannula into the antecubital fossa. So that's another thing that's really important you establish. We spoke about catheterization, giving fluids, medication at this point as well will be relevant, and considering cardioversion. If you're going to be giving medication at this point, what is it really important that you check? Whether that's in the notes, asking the nurse, asking the patient if they're able to talk to you. What's a really important consideration at this point? Allergies, fantastic, thanks Ria. So make sure that you're checking the allergies before any sort of medication, especially if classically you might be giving, broad spectrum antibiotics. So at that point, you need to be checking for things like penicillin allergy. Right, we're going to speed through the rest. So D, you guys did say before disability. So the sorts of things you want to be looking for. So focal neurology, convulsions, PEL. Does anyone know what PEL stands for? Normally classically documented in kind of the acute med setting when you're doing a very quick ATE assessment. Any ideas as to what that could stand for? So it stands for pupils being equal and reactive to light. And that will be documentation you guys might see very frequently, especially in your acute med placement, so useful to know. Feeling for focal weakness, and then for listen, it's not really applicable to the disability part of this. And in terms of what you might measure, there's a really good point at which you're going to be carrying out either GCS or an AVPU score. Classically, I would say it's good for you guys to be familiar with what the Glasgow Coma scale is and how you measure that. But in an OSCE, PEL was pupils equal and reactive to light. Maybe Niraj can type that in as I continue speaking. In an OSCE context, it's quite useful to probably use the AVPU score, to be honest. So that's, is the patient alert? Are they verbal? Are they in pain or unconscious? So that's a lot easier to be able to assess, especially in an OSCE station context. So just know that you're either measuring the GCS or the AVPU, but most commonly AVPU is the easiest to go with. And also, very importantly, measure the blood glucose. That's another one that's very easily forgotten, but very important that you measure that as well in the context of something like hypoglycemia, for example, or DKA. And you're treating with things such as glucose, anti-epileptic drugs, depending on, again, what the situation is. So we've come to the last letter. What does E stand for? And I've got 1 minute before I hand the reins to Niraj, so we've got a few more slides to get through. Everything else, good suggestion. It kind of is everything else, to be honest. It stands for exposure. Yeah, well done, Ria. It stands for exposure, but the sorts of things you're doing. So at this point, you've got the mannequin, you're quite literally just moving the blanket away and you're looking at everything else. So, are there any sites of bleeding, any rashes that you might not have noticed until this point, melena wounds, injuries? You're going to be feeling for any injured limbs and also the abdomen, very importantly. So you're going to be feeling if the abdomen is soft, non-tender. Yes, James has put, yeah, exactly, anything below P, you'd want an anaesthetist. You're going to be taking a full history at listen as well, and then in terms of measure, a temperature, which is very useful. Because you did do the peripheral temperature in C, but this is now actually measuring either the temperature through the ear, rectal temperature, something along those lines. And in terms of treating things depending on what you've been told in the exam. So often this is dealing with any wounds, potentially pain management if you haven't done that already. So just to summarize, make sure that with each measurement that you've taken, you're reassessing them. So once you've done, let's say, oxygen and respiratory rate in A, in B, once you do some kind of treatment, you say, can you give me an update as to what the oxygen stats are now, what the respiratory rates are now? Because the chances are it may have improved, but you're not going to know that if you don't reassess. So bear that in mind. Often in an OSCE context, if it's a 10-minute station, you might need to do an S-bar handover. If you guys don't know what that is, then we can definitely do a session on that. But that's very useful to get to grips with early on as well. And you will see S-bar handovers when you're in clinic. Doctors do them often when referring patients. So that's very useful to get familiar with early. Make sure you're checking the patient notes. It could be sitting on the desk whilst you're literally in your OSCE station, but you just fail to think of looking at the actual notes. And make sure at the very end you say you're going to document your assessment. So this is a clinical scenario. I'm aware that it's 32 pass, so we might just skip right to the kind of full assessment, but have a read of this clinical scenario because you guys are going to be reviewing this patient towards the end of the presentation. So
I think you've got a bit of time, Sylvia, because we only started at 5 past, so don't worry too much.
Fine, perfect. Cool, I'll use the last 5 minutes to do this. So now that you guys know the ATE assessment, we're now going to be applying it to Grace Johnson. So imagine you've been told this outside in the station, you're now going to come in and do doctor's ATE. What's the first thing that you guys are going to do? So quick fire in the chat. Now you know what doctor's ABCDE is. You've walked in. What are you going to do? Look for danger. Perfect. Thank you, Ria. So you tell me you're checking for danger. I'm going to say, okay, it's safe to approach the patient. Fantastic. So an example there, sharps, good. So once I've told you it's safe to approach the patient, what are you going to do next? Check for a response. Exactly. How are you going to do that? Call for the name. There you go. You've preempted my question. Good. So when you kind of go and say, hi, Grace, you know, I'm Dr. Sylvia. I'm here to help you. She's responding, but she's very confused. She doesn't understand why she's in hospital. So you've got a response now. You know she's talking, but confused. What are you going to do next? Check airway, exactly, and reel off a few things that you guys are going to be looking, feeling, listening for, what sort of things you might be measuring. Foreign objects, excellent. What measurements do we want? Palpate the trachea. So the trachea was in breathing. Look for tongue swelling, excellent. Really good suggestion, guys. Oxygen and respiratory rate, exactly. So oh, I'm sorry, trachea isn't airway. Well done. So you're looking for any obstructions. There aren't any obstructions. You've checked for the trachea, as Theo said, and it's central. You're listening for any abnormal breath sounds. Everything's normal, and your measurements are 89% oxygen saturation and 26% respiratory rate. What do you guys want to do about those figures? Is that looking good to you, or are you a bit worried? Get oxygen up. And how are we going to do that? Give oxygen. Fantastic. Well done. So that's what we're going to do. And then I'm going to move on to breathing. So in terms of what you've been told about breathing, I'm sure you guys would have said you're going to check for expansion, respiratory distress. So there are some signs of respiratory distress. The patient's slightly cyanosed here as well. Chest expansion's fine. You're percussing at the bases of the lungs and it's quite dull. Remember, she did come in with pneumonia. You're listening to the lungs with some crackles on auscultation, and because you've remembered to reassess, you've been told after oxygen, the sats have gone up to 92% now, and the respiratory rate's a little bit lower with 24. You've been told the ABG is pending, and we'll be having a look at that later on. and your chest X-ray you remember to order as well. NRBM is non-rebreathe mask. Okay, perfect. So C, what sorts of things are you going to be looking for, feeling for, measuring? If you all just say one thing that you remember that we have to do in circulation. Feel for the peripheral temperature. Excellent, Maria. Thank you. Feel for the pulse. Excellent. We also want to be measuring the heart rate as well. Well done. And this is the one where there's a whole host of things, so we'll keep going. So you're looking, feel for edema. Excellent. So you're looking for any cyanosis. So the patient's cyanosed, she's sweaty, she feels quite warm. There's a weak and rapid pulse. Heart sounds are normal. And so you do your long list of measurements. So the heart rate's 130. Capillary refill time is 5 seconds. And blood pressure is 90/60. And your urine output's reduced. So what sorts of things do you guys want to do at this point, given those figures? Are you worried about any of those measurements? Okay, so the heart rate is above 100. What's normal BP, everyone? Yeah, good question. So very quickly, the normal blood pressure, 120/80, excellent, Theo. And what capillary refill time would you want in a healthy person? 2 seconds, yeah. So in this case, the capillary refill time's delayed and the blood pressure is very low. So 90/60 is one of those thresholds where you are most definitely going to be giving a fluid challenge to bring that blood pressure up. And remember, we spoke about giving 2 wide bore cannula into the antecubital fossa to give a fluid challenge. We know the urine output's reduced. I haven't told you whether the patient's catheterized or not, but in the case that she's not, we want to catheterize the patient as well. So there's some of those treatment algorithms. So I think what's quite hard with ATE is, as well as giving those figures, you guys need to think about what do I want to do to improve those as well. So D is all normal. In terms of exposure, all normal aside from a high temperature, which is, you've been told, 39 degrees Celsius. So what do you guys at this stage think is going on, if you just had to guess? So if I put this slide up and tell you that's all the information you've been told, and you had to put forward some differential diagnoses, what sorts of things will you be thinking of? Thanks so much, that's useful. Pneumonia, infection, yeah, good. So she's come in with pneumonia. Edema, there weren't any signs of edema with this patient in terms of what stats you've got, but I can see why you might be thinking along the sides of edema. That's more so a feature as opposed to a potential diagnosis that would be causing this picture. But I do think it's fair to say that there's something going on with this infection. So what will help us figure out what's going on? Oh, interesting animation. Right, so we're going to do an ABG, and now Niraj is going to take you through that step by step. Niraj, let me take you. There you are. Oh no, sorry. Can you request permission again?
Yes. You took it back.
Right, there you go. Right.
All right, thanks Sylvia. Thanks. So Sylvia's gone through how to do an ATE assessment really thoroughly. So we'll do some practice on that at the end, but I'm just going to take you through the ABG aspect of things. So you might have done a bit of ABG teaching in the past, ABG learning rather in the past, in circulation and breathing, and I think at various points throughout year 1. But it's a really important topic for both OSCEs and SBAs. So we're just going to go over the basics, but also add some clinical context to this. If at any point there are things that aren't making sense, then please do post them in the chat, and myself, James or Sylvia will get to them and answer your questions, all right? So this is the general approach to how you look at an ABG. So first of all, with any kind of investigation, you need to confirm it's the right patient and it's the most up-to-date result. So if you've got an ABG or an ECG in an OSCE, you should make a really big, like you look in the mirrors during a driving test, you should make a really big point of kind of like taking the ABG and reading it out and saying, you know, this is an arterial blood gas of Mr. John Smith, date of birth, blah, 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 taken today at 6:30 p.m. All right, so just make sure that it's the right patient, the right ABG. The second thing, before you even look at the results, is think about why are they having this done? What's the indication? So in Sylvia's patient, whose name I can't remember, in that scenario, the ABG is being done because the patient's critically unwell. Some people have ABGs done because they're at an outpatient, like a respiratory outpatient clinic, for example, and Grace Johnson, and they want to have a look at the patient's oxygenation. And why are they having an ABG done instead of a VBG or even a capillary blood gas? So if you guys could, if you guys have any ideas about when you might do a VBG instead of an ABG, please do post them in the chat, and if not, then I'll come back to that at the end. The next thing you're going to have a look at is oxygenation. So how well oxygenated is the person? Then we're going to have a look at ventilation. So how effectively are they moving air in and out of their lungs? And to do that, we'll look at their carbon dioxide. Then we look at their acid-base balance. So are they acidotic? Are they alkalotic? Is it a metabolic cause of that derangement or a respiratory cause? And if there is a metabolic acidosis or a respiratory alkalosis, is it compensated by anything else? And don't worry, we're going to go through what all of this means again in a second. Then we're going to have a look at everything else. So things like the lactate, the electrolytes, the glucose and the hemoglobin that you also get on an ABG printout. So there's a lot of information, but we're going to break it down and go through it step by step. So the first thing we're going to look at is oxygen in the ABG. Now this is given to you as a partial pressure of oxygen in kilopascals, so kPa. And the reason we look at oxygen first is because hypoxia kills really quickly. And it's one of the 4 H's and T's of cardiac arrest causes, which you should be familiar with, or we can go through at another point. So you first of all want to have a look at the oxygen, and you always want to have a look at the oxygen in the blood relative to how much they're breathing in. So obviously, if somebody's breathing in room air oxygen and their oxygen's a bit low, you can put them on some oxygen and see how it comes up. Whereas if somebody's breathing in 15 liters per minute through a non-rebreather mask, that's close to 100% oxygen, you need to have kind of a different normal range in your head for what their level should be at. So as a rule of thumb, we normally say that the oxygen should be about 10 kilopascals lower than the percentage that they're breathing in. So if Grace Johnson's breathing in 100% oxygen, really we would expect her PaO2 to be about 90, okay? If we're breathing in 21% oxygen now, we would want our PaO2 to be above 11. And if somebody's PaO2 is less than 8 kilopascals on room air, we say that they're in respiratory failure, all right? So there are 2 different types of respiratory failure, type 1 and type 2. And just in the chat, could anybody tell me what the difference between those 2 types is? Yeah, exactly. Yes, exactly. Great. So both of you are absolutely right. So in type 2, you have hypercapnia, and in type 1, you have normocapnia. So you've got normal carbon dioxide. And could you therefore give me some causes of type 1 and type 2 respiratory failure? Don't worry if not, we're going to go on to some causes on the next slide. Now I've put these things, I think you can see my laser pointer, I've put these little valves in the bottom right, because when we're talking about how much oxygen someone's breathing in, there are lots of different ways to control that. So when you give somebody oxygen when they're critically unwell, you normally just slap on 100% oxygen. You can also use Venturi masks, which you might have seen during your practical sessions at the medical school. So you can carefully titrate the amount of oxygen somebody's receiving. That usually happens in COPD. So for example, if they've got a green on, you know that they've got 60%. You don't need to memorize these colors. They are printed on the valves themselves. And you can also have a look at various different resources for finding out how much oxygen someone's on compared to how many liters per minute they're breathing in. So these are some causes of type 1 and type 2 respiratory failure. Now, the way I like to think of this is type 1 is lung failure and type 2 is pump failure. So in your type 1, you've got pneumonia, so including things like COVID pneumonitis, acute respiratory distress syndrome or ARDS, pulmonary edema, pulmonary fibrosis, and a pulmonary embolism. So those all cause issues of oxygenation primarily. And the type 2 respiratory failure is usually a pump failure, so when the air can't get in and out of the lungs very well, and that's a failure of ventilation. That's why you get the hypercapnia as well. You can have neurological causes, so if somebody's had some kind of nerve injury, remember whichever nerve roots keep the diaphragm alive. For the phrenic nerve, so if you have a transection of the phrenic nerve, for example, the person will die, but if you've got any kind of neurological issue, you're going to have a type 2 respiratory failure picture. Neuromuscular causes, so things like motor neurone disease. Actually, that's a neurological cause. So neurological causes like motor neurone disease, neuromuscular causes like myasthenia gravis. If somebody has an issue with their neuromuscular junction and their muscles of respiration can't contract and therefore they can't blow off that carbon dioxide. Any obstructive lung disease, so things like COPD and asthma, which mean that the normally very big trachea is kind of tightened up and people can't blow out all of that carbon dioxide. And occasionally restrictive disease, when it gets really bad, can cause a type 2 type picture. Now, in terms of the management, they're slightly different. So type 2, initially you slap on 100% oxygen and then find out what's happening. And then for type 2, you usually want to do what's called non-invasive ventilation, which Sylvia alluded to previously. You want to help them get CO2 blown off using something like BiPAP, but we don't need to go into that today. Just bear in mind that type 2 respiratory failure is mainly a pump issue. And then we have a look at carbon dioxide. So again, you get this as a partial pressure in kilopascals, and it's a marker of how efficiently you're ventilating. So as you guys have said in the chat, type 2 respiratory failure is hypoxia with hypercapnia. And that hypercapnia might be acute, such as in a drug overdose. Someone's had an opiate overdose and they can't breathe properly because they're in respiratory depression. Then they might have an acute hypercapnia or a chronic hypercapnia, for example, in COPD. And hypercapnia is quite dangerous because it can cause delirium, confusion, and agitation, and then eventually bradypnea and CO2 narcosis, which is a state of coma due to CO2 intoxication. And the management, as I said, is usually non-invasive ventilation or invasive ventilation, where you actually put a tube down somebody's throat and breathe for them. Now, I just want to draw your attention to the box on the top right. Can anybody tell me what's happening here? So on arrival to ED, this person's had an ABG done. They're having an asthma attack, and 15 minutes later, they have another ABG done. So could one of you two tell me what you think is, one of you three rather, tell me a bit about what you think might be happening? And if not, just describe what's going on. And feel free to unmute if it's quicker for you than typing. Exactly, Theo. So, exactly, Hugo. I think you mean not expiring the CO2. So both of you are exactly right. So what we can see is if we look at their on arrival ABG, they're quite profoundly hypoxic on 100% oxygen. That's 9.6 kilopascals. It's not very high for somebody who's breathing 100%. And they're actually hypocapnic. And the reason that they've got a low CO2 is because they're breathing so fast and they're struggling to breathe. So that's why their CO2 is slightly lower than it should be. But 15 minutes later, their CO2 starts to rise, and that means that they are tiring of breathing, and this is either a life-threatening or a near-fatal asthma attack. So what should happen now is that you're done with all of your inhalers and your salbutamol, ipratropium, magnesium. None of that's going to help this person now because they're in very severe respiratory distress. They need to be intubated and ventilated. So make sure you look out for, in SBAs and in OSCEs, etc., if you've got a high or normal carbon dioxide in somebody with an acute exacerbation of asthma, that's a very worrying sign, and that's something that you need to be aware of, because it can be reassuringly normal. You look through the ABG and think, oh yeah, that's all normal, but really it's not. Okay. All right. Now we have a look at kind of the acid-base balance. So before you look at the rest of the stuff on the slide, if you just have a look at the grey box on the top right, sorry to traumatize you with some year one content, but the bicarbonate buffer system is basically how we maintain our pH. And there are two ways that happens. So the excretion or the retention of hydrogen carbonate ions or bicarbonate ions from the kidneys, and then the blowing off of CO2 from the lungs. All right. So if you excrete, if you excrete more bicarbonate ions, then you become more acidotic because you're getting rid of base. And if you retain more, then you become more alkalotic because you're keeping that bicarbonate in your body. And in terms of respiration, if you are breathing out less CO2, that CO2 turns into carbonic acid and makes your blood more acidic. But if you're ventilating really fast and you're blowing off all of that CO2, then you become more alkalotic. All right, and that's how type 2 respiratory failure fits into the respiratory acidosis. And each of these things can compensate for one another. So if you've got a respiratory acidosis, the kidneys over time can create a metabolic alkalosis to try to compensate for it. And if you've got a metabolic acidosis, then the lungs can try to create a respiratory alkalosis and try to compensate for what's going on. But that compensation does take time. So alkalosis is when your pH is above 7.45, the normal being 7.35 to 7.45. And the way you can tell it's an alkalosis is via the pH, and to tell whether it's metabolic or respiratory, you need to look at these two things. You need to look at the bicarbonate and you need to look at the CO2. So if your bicarbonate is high, then you know that it's a metabolic alkalosis. If your carbon dioxide is low, then you know it's a respiratory alkalosis. So there are a few causes here, which I'm not going to go into, of a metabolic alkalosis, which you can read about in your own time. And the main cause of respiratory alkalosis is blowing off too much CO2, for example, in hyperventilation. So if you simple anxiety attacks, asthma attacks, very importantly also in a pulmonary embolus, if somebody is hyperventilating because they're short of breath, they might blow off a lot of carbon dioxide. So that's another thing to be aware of. So that's all I'm going to say about alkalosis today. But if you've got any questions, then please do post them in the chat. And feel free to interrupt and stop me at any point, because I know this is a lot of content that I'm trying to cover quite quickly. All right, now we go on to acidosis. So same thing with the lungs and the kidneys. So acidosis happens if you're not blowing out enough carbon dioxide, or if you are losing too much bicarbonate. pH in acidosis is less than 7.35. And again, how do you tell if it's respiratory or metabolic? You look at your carbon dioxide and you look at your bicarbonate. So if your CO2 is high, then you've got a respiratory acidosis. So that's your causes of type 2 respiratory failure as well. So things like respiratory depression, head injuries, drugs like opiates, for example, neuromuscular or neurological disorders, or in obstructive lung disease, so things like COPD, where you're not blowing out that carbon dioxide properly. Metabolic causes, there are loads, which we're going to go on to in the next slide. And interestingly, you can also have a mixed picture. So if you've got a high CO2 and a low bicarbonate, then you've got a mixed respiratory and metabolic acidosis. And this is usually seen in cardiac arrest, post-resuscitation or during resuscitation. The reason being, obviously, ventilation is not adequate, but also you get a build-up of anaerobic byproducts, which causes the metabolic acidosis. Now, I'm not going to cover this in too much detail. The slides are here for your reference, but One of the new things that comes up this year is how to categorize a metabolic acidosis. How can you tell what's causing it, or at least how can you narrow down what's causing it? Has anybody heard of the anion gap before? Okay, so Thea has not. Yeah, so it's one of the, it's kind of niche, but it is important to know, especially for exams. So the anion gap is basically this formula here at the top. It's a look at the balance of cations and anions. And the reason that we do this is because we don't measure all of the anions that are in circulation. So things like albumin, phosphate, and sulfate aren't measured usually. And that's the anion gap basically tells us a bit about how many of those there are. You don't need to know much about it. Just know that the way it's calculated is usually sodium plus potassium minus chloride plus bicarbonate. And these are the main cations and anions that you see on the ABG printout anyway. The normal anion gap varies between machines and between hospitals, but it's between 4 and 12. Now, all you need to know is that if you have a high anion gap, that means somebody is producing more acid or they're ingesting acid, okay? So if they're producing acid or ingesting acid, then the anion gap is going to be high. And a normal anion gap metabolic acidosis is when you're losing bicarbonate from the kidneys, or sometimes producing chloride or ingesting chloride, but you don't need to worry too much about that. So with that in mind, knowing that this is the most important, by the way, so knowing that high anion gap means that you've got an increased production of acid. Does anybody want to hazard a guess at any causes of a high anion gap metabolic acidosis? Okay, so a really important cause is diabetic ketoacidosis. So if you've got a diabetic who hasn't had their insulin and their body starts using ketones and producing acids, you get an increased amount of acid being made, and that's ketoacidosis. You also get it in sepsis, which is something we're going to talk about in a minute, and some toxin poisonings as well. As I said, I'm not going to cover this in a lot of depth, but do have a look at the slides in your own time. It's just a way of categorizing the different causes of metabolic acidosis. So I want you guys to have a look at this ABG. We're not using VVox. I know that someone's just joined us. We're not using VVox, we're just using the chat. So why don't you take a couple of seconds to have a look at this ABG and decide what your next step in management should be. Now, I'm going to stop talking so you can focus in a second, but the thing with UCL questions is that a lot of them are multi-step, so it won't just be, this is an ABG, what's it showing? It might be, this is an ABG, what do you need to do now? And that entails knowing what it's showing. So why don't you guys take 30 seconds to have a look at this? All right, any ideas for the chat? And by the way, don't worry about the base excess. The base excess tells you the same thing as the bicarbonate. If the base excess is high, the bicarbonate is high. If the base excess is low, then the bicarbonate is low. So you can look at one or the other. Good thinking, Theo. E. Hugo, high flow. Yeah, so you've all got it. So this is severe type 1 respiratory failure. So this person's only breathing in 21% oxygen at the moment, room air, and their PaO2, the PO2 is 5.2, so it's not good, is it? So this links into Sylvia's thing. Your treatment for B would be start high flow oxygen. You will do the rest of these, well, you won't do B, but you'll do the other stuff. It's just not the most appropriate next step in management. let's have a look at this one. This one's slightly more tricky. Any ideas? Got 2 for C. Any more ideas? We've got 2 more people on the call. No worries if not. Okay, not a bad shout, C. Mostly, yes, good, Ria. So mostly when you get when you practice a lot, then you'll kind of get the answers without reading the rest of the stem. So if this was a 25-year-old man or woman with no significant medical history, suddenly developed numbness and tingling around the lips and shortness of breath, then yes, I would say it's an anxiety episode. But this guy is fairly, well, he's a bit older. He has a history of cancer and he's recently undergone surgery. So those things are risk factors for a pulmonary embolus. And he suddenly developed shortness of breath, and he's now got a respiratory alkalosis. And this is because he might have developed a PE and is now out of, fighting for breath. And this might deteriorate into a type 1 respiratory failure, depending on what happens. If anybody knows the treatment for a PE, then do post it in the chat and we can talk about it later on if we get time. Okay, another one. Any ideas for this one? And yeah, good, Hugo. So a PE, you can thrombolize if it's causing hypotension. So if it's causing circulatory collapse, you would want to thrombolize. If it's not, then the risk-benefit balance shift towards giving them blood-thinning medication. So something like low molecular weight heparin or a DOAC, so apixaban, etc. Any ideas for this ABG? This is the penultimate one before we have a look at some other things and then go back to the case. Good, Theo, yeah. So it's a chronic type. This time we've got a guy with kind of chronic type 2 respiratory failure, chronic respiratory acidosis with full metabolic compensation. And you can tell this is probably chronic because the bicarbonate's pretty high. And so this is clearly developed over quite a long time. The FiO2 is 30%. Using that information and the fact we've got a chronic respiratory acidosis, does anybody want to hazard a guess as to which condition could be underlying all of this? Exactly, COPD. So FiO2 is 30%. He's probably on some long-term oxygen therapy through a nasal cannula. Yeah, exactly, great COPD. And he's got a long-standing sort of, he's a bit hypoxic with a high CO2 and also a high bicarbonate. So well done, guys, it's good. And this is the last kind of practice one before we have a look at some other stuff very quickly. Okay, any ideas? What's the most appropriate next step in the management of this fictional patient? Yeah, FBCs, yeah, could be. So this is another sneaky question. It's another sneaky question because it's what's the likely diagnosis? The likely diagnosis here is DKA, okay, diabetic ketoacidosis, because it's a young guy with high anion gap metabolic acidosis. I would say they should have already done a capillary blood glucose, but I would say that's the next best thing to do because it's really quick. So you can do FBCs, LFTs, etc. It's going to take time for the results to get back. You can do a urine dip. I guess you could look for ketones in the urine dip as well. But by the time you get a urine sample, you could just do a finger prick blood glucose, and that will tell you if the glucose is sky high, then you know this is likely DKA. We're going to wrap up soon. The rest of these slides are basically for your own sort of interest and kind of reference. So quickly, lactate is another thing. That's all right, Ria. So lactate is another thing that we measure on ABGs, and it's just a marker of being critically unwell. We also have a look at electrolytes on the ABG, so things like sodium, potassium, etc. And I've just put in a note about hypokalemia here because those are important things that come up all the time and also important for clinical practice too. So have a look at that in your own time. Now let's go back to Sylvia's patient. So we said that Sylvia's patient was hypoxic. Yep, they were hypoxic, they were hypotensive, and they were tachycardic, and also I think might have had a fever as well. So let's put that together with the ABG. What do you think is going on with Sylvia's patient, Grace Johnson? Any ideas? So we had a hypotensive tachycardic patient, so we know that she's shocked. Ria, before she left, said it's something to do with an infection. And now looking at the ABG, we can see that she's got what going on in the ABG? And just because I'm conscious of time, if you don't have any ideas in the next couple of seconds, I'll tell you. Yep, good. So she's got type 1 respiratory failure, metabolic acidosis, and putting that together with a high lactate, which you see in critical illness, and the hypotension, and the tachycardia, and the fever, she's probably in septic shock. Okay, so this is probably sepsis, as Ria said, an overwhelming infection that's causing all sorts of trouble and all sorts of metabolic derangements. So again, this is a slide for your reference, but it's really important to commit this to memory as well. The sepsis 6, again, comes up in OSCEs all the time. You need to give 3 things and take 3 things. So you need to give oxygen to keep the SATs above 94, so we've done that. You need to give IV antibiotics ASAP. You need to give a fluid challenge, so that's usually 500 milliliters of saline over 15 minutes through a wide bore cannula. You might want to give a bit less if the person's known to have heart failure because they could become fluid overloaded. And you want to take blood cultures to find out what the organism is that's causing the sepsis. You want to take some blood to measure lactate, like we just did, and also put in a catheter and take some urine, measure a urine output to see whether the person's kidneys are being perfused well. So that brings us to the end of the presentation. We're sorry that we ran 10 minutes over time. We are happy to answer any questions, though. We'll be hanging around. In the meantime, please feel free to give us any feedback. It's mine and Sylvia's first session, so if you've got anything that could, any improvements, any constructive criticism, that's all most welcome.